Good morning, friends. I am Dr. Captain D.K. Ramawat, consultant non-invasive cardiologist working at Ramawat Heart and General Medicine Hospital, Badmer. Today we are taking a very important topic, that is intracoronary stent restenosis. Listen it. Intracoronary stent restenosis, diagnosis and management strategies. Although all the doctors are doing giving the streptokinase etc. for thrombus formation, but if it is the thrombus is after stenting, means intracoronary stent, and then there is restenosis, thrombolytic therapy cannot be given. Then what to do? This we will discuss in detail. So let us start. So we are taking intracoronary stent restenosis, diagnosis and management strategies. Welcome, friends. This is intracoronary stent restenosis, the diagnosis and management strategies. First of all, we will discuss the introduction. Advances in percutaneous coronary intervention have facilitated the management of multitude of complex coronary artery lesions. These include the development of drug-eluting stents, which superseded the use of bare metal stents. Though drug-eluting stents have significantly reduced target vessel revascularization by reducing the stent failure, both types of stent are at risk of in-stent restenosis. In-stent restenosis in bare metal stent and in drug-eluting stents have subtle differences. The only little difference in mechanism and timing and offer different challenges in diagnosing the mechanism and subsequent treatment options. A recent report from National Cardiovascular Data Registry in 2020 has estimated that in-stent restenosis interventional presented 10% of all PCI procedures in the United States, highlighting that though significantly reduced from BMS era, but the prevalence of ISR is not uncommon and remains a challenge in modern practice. Now, what is the definition of ISR? ISR, matlab in-stent restenosis. So definition is restenosis may take place in the form of a gradual narrowing of stented segment, which most commonly occurs in the first 3 to 5 months in the PCI. Clinically, this may present as recurrent enzymal symptoms. Second, may occur as acute coronary syndrome in approximately 10% of the patients. The definition of ISR varies, but the most recent consensus is summarized in the following 3 bullet points. Number 1, restenosis, luminal diameter reduction because of new intimal tissue proliferation. Second bullet, binary angiography restenosis, that is more than 50% luminal narrowing at subsequent angiography. Third bullet, clinical restenosis, the presence of both binary angiographic restenosis and clinical symptoms and signs of ischemia either at rest or with stress. And lastly, restenosis with a more than 70% reduction in luminal diameter, even in the absence of clinical symptoms or signs. Now we have come to signs of ischemia. In this definition include: first, ECG changes will be there. Secondly, you will see positive cardiac enzyme. Third, you will see limitation of coronary flow as measured by intracoronary physiology testing that we do by FFR. FFR means fractional flow reserve. Now, what are the incidents? The incidence of ISR. Restenosis rates are generally high in complex lesions such as small vessels. Second, calcified lesions. Third, bifurcation lesions. Fourth, chronic total occlusion CTO. Other main factor related to type of stents. Now we will discuss this. First we take the bare metal stent. From 6 large clinical trials, the incidence of ISR in BMS stented lesions was defined as TLR, that is target lesion revascularization, or TVR, means combination of TLR plus target vessel myocardial infarction plus cardiac death beyond 30 days. At 12 months, TLR was reported in 12% and TVR in 14.1%. Clinically relevant ISR is called, that is, first symptomatic patient, second positive ECG, third positive cardiac enzyme occurred in half of the patient, and angiographic restenosis of more than 50%. Now we must know the incidence of TLR was much higher in angiographic restenosis of more than 70% compared to those with TVR, that is less than 60% restenosis. Now we will discuss the drug-eluting stents. Here stents, here in stent restenosis in drug-eluting stent reported to between 2 and 20%. First generation DES, known as sirolimus and paclitaxel, has ISR rate of 13 to 16% at 5 years. Second generation drug-eluting stent called everolimus and jotarolimus had TVR rate of TVR rate for ISR at 5 to 6%. Now all types of DES have been reported in multiple studies to reduce ISR and TLR by 50 to 75% compared with bare metal stents. Now let us take the factors influencing the development of ISR. A number of factors have been reported to influence its development. These are summarized here in table 1. So first, and these factors are either pharmacological, biological, of the patient, of the lesion, or mechanical. In pharmacological, drug resistance may develop of the antiplatelet drug, and there can be hypersensitivity to the drugs, or there can be hypersensitivity to polymer in the stent. Then biological, proteolytic enzymes and matrix metalloproteinase, and in patients only risk factors like diabetes, older age, female gender, and genetics. Then if we go for lesion, factors for lesion, if the lesion is long, more than 20 mm, or if the lesion is type B and C, if the small vessel is there less than 3 mm, or the lesion is calcified, or lesion is bifurcated, or lesion is chronic total obstruction, or lesion is ostial segment, or lesion is in tortuosity of the vessel. And now mechanical. First is stent malapposition. So stent malapposition means what? Incomplete stent apposition, that is separation of at least one stent strut from the initial surface of the arterial wall with evidence of blood behind the strut without involvement of the branches. Then second mechanism is stent under expansion. Then third, age trauma. So age trauma is what? Vessel injury from ballooning or stent implantation after angioplasty that occurs at the age of the stent. The fourth and the last, stent fracture. And one more, which I forgot to discuss, geographical miss. Geographical miss what? When any segment of the stenotic or injured vessel is not included in the radiation field or is treated to an inadequate dose, is called geographic miss. Now let us go for the pathology of the ISR. ISR in BMS occurring mainly as a consequence of arterial damage, whereas these drug-eluting stent, it is due to an inflammatory reference and potential hypersensitivity to polymer and drugs, leading to delayed endothelization and neoatherosclerosis. Within the first 2 weeks following PCI, there was accumulation of fibrin, platelet, neutrophils at the site of stent implantation, indicating inflammation and thrombus formation. Now we will go to pattern of ISR. They have been categorized to focal or diffuse. These were further designed, classified angiographically in a study of 288 ISR lesions in 245 patients who had received BMS. Pattern 1, focal, less than 10 millimeter in length. Here, rate of repeat TLR was 19%. Second pattern, ISR more than 10 millimeter within instant. Rate of repeat TLR was 35%. Pattern third, ISR more than 10 millimeter extending outside the stent. Rate of repeat TLR was 50%. Pattern 4, totally occluded stent. Rate of repeat TLR was 83%. Now we are going to for diagnosis and assessment of ISR. Patients who have had previous PSI and stent implantation and experience ISR may present with symptoms of stable ischemia, that is angina, or with acute coronary syndrome. Now coronary angiography may also provide clues to the mechanism of ISR by demonstrating underexpanded stent or calcification outside the stents. In more contemporary practice, intracoronary imaging by intravenous ultrasound and optical coherence tomography has been found to be essential in providing the precise mechanism of ISR, including stent under sign number 1, second malapposition, third geographical miss, fourth is your this differentiating tissue pattern, neointimal hyperplasia or neoatherosclerosis, and fifth age stenosis, a type of ISR that occurs at the age of the stent after angioplasty, and lastly underlying calcification. For indeterminate cases where an objective assessment of ischemia is required, a pressure wire-based index. Listen it very perfectly. For indeterminate cases where an objective assessment of ischemia is required, a pressure wire-based index, for example FFR, fractional flow reserve, or IFR, instantaneous wave-free ratio, may be used to assess the flow across the ISR lesion and guide the operator's decision on whether or not to proceed with repeat PCI. Now we are going to management of ISR. So in management, first we have to see undersized stent may simply require balloon dilatation, and that is okay. Then second, more complex ISR lesions with neointimal hyperplasia or neoatherosclerosis may require debulking with tools such as atherectomy or scoring balloons. Here you have to note that the use of intravascular imaging is mandatory in these cases. Given the wide choice of revascularization option, a number of studies have compared PCI strategies for treatment of ISR. These are summarized in table 2. You can read it and follow it. Now we are going to the majority of patients with ISR who undergo revascularization will likely undergo repeat stenting. In fact, in 2014, European Society of Cardiology and European Association of Cardiothoracic Surgery guideline, what the guideline? Guideline on myocardial revascularization recommends either DES, drug-eluting stent, or DCB, drug-coated balloon, for the treatment of ISR, irrespective of stent type, whether it is BMS or DES. Now CABG, when the CABG should be done? CABG should be considered in patients who are not suitable for PCI, number 1. Second, who suffer from recurrent ISR despite drug-coating balloon or drug-eluting stent. And lastly, CABG is indicated in those persons who suffer from multi-vessel ISR diseases. The recommended choice of DES is an everolimus eluting stent. The recommended choice of DES is an everolimus eluting stent. This was shown to be superior to other devices in a network meta-analysis of 27 clinical trials. In addition, there was a lower TLR target lesion revascularization with EES, everolimus eluting stents, compared to all other strategies including other DES. The use of drug-eluting balloon angiography is also reasonable in patients who may not be suitable for DES implantation. Now, the patient population that may benefit from DCB, drug-coated balloon, includes those who are not candidate for long-term dual antiplatelet therapy. This is number 1. And second, who have multiple layer of metals. And third, when compromise of a side branch is concerned, which occurs during PCI of a bifurcation lesion. Then where debulking is required, the use of rotational or lesser atherectomy may be indicated. Scoring or cutting balloon are used in these circumstances given their wider availability and relative safety compared to atherectomy. The evidence of lesion preparation techniques in ISR presented in table 3. You can read it thoroughly. Now we are going to a very important chart. This highlights the mechanism, the management pathway that can be considered for treating ISR lesion. So, first we will do the angiography. If in stent restenosis is seen, supposing, and if it is severe, then we will go to intravascular imaging by intravascular ultrasound or OCT, optic coherence tomography. And if we see that undersized stent is there, then what to do? Then go for scoring balloon or non-compliant balloon, and then you can deploy the drug-coated balloon. And if you see in IVUS or OCT unexpanded stent, then go for atherectomy, rotational or lesser, or lithotripsy. If you see in IVUS or OCT neointimal hyperplasia or neoatherosclerosis, then go for scoring balloon or cutting balloon or lesser atherectomy or brachytherapy should be used. And if you see age lesion, now the point comes, what is age lesion? Age lesion is diameter of stenosis of more than 50% at the proximal and distal edges of a stent, and you feel weakness and numbness. So if you see the age lesion, go for drug-eluting stent or drug-coating balloon depending on situation. If you see stent fracture, then go for drug-eluting stent. And supposing angiographically this restenosis is not severe, then no revascularization indicated. Now, lastly we will discuss clinical cases for in-stent restenosis, focusing on diagnosis and management. These are the examples, what they did. There are 5 cases. First we take the first case. Case number 1. A 78 years old male with a history of PCI to the left antidescending artery 3.5 years ago. They present on this occasion, after angiography, with non-ST vessel myocardial infarction with anterolateral T wave changes. Coronary angiography demonstrates ISR in the LAD stent and de novo disease proximal and distal to stent. Also we saw OCT images demonstrating the presence of neoatherosclerosis within the ISR. In this case, lesion preparation took place with semi-compliant balloon in the de novo disease area within the ISR, and we deployed the drug-coated balloon, and you can see that stenosis is removed. It is clearly, you can see the last figure, stenosis is removed. Now case number 2, a 56-year-old male with a history of PCI to left main stem into LAD and circumflex artery in 2013 with Coolity technique. He experienced a recurrence of symptoms and he had drug-coated balloon treatment to ostial and proximal circumflex and in-stent restenosis in 2018 in an outside hospital. They represented in 2019 with recurrence of symptoms in keeping with unstable angina. Angiographically demonstrates significant ISR in the ostial and proximal circumflex branch. Then intravenous ultrasound demonstrates the mechanism of progression of neoatheroma with an undersized stent, means 3.5 mm only, and there was also underexpansion of stent in proximal segment due to fibrocalcifications. So here the proximal circumflex lesion was treated with intravascular lithotripsy, shock waves. In lithotripsy we apply shock waves to disrupt the underlying fibrocalcific disease. This was followed by the deployment of an ultra thin stent in the circumflex. So you can see here the last figure, world's first thin stent, fully dissolvable. Remember, fully dissolvable stent developed in India. So this was followed by the deployment of an ultra thin stent in circumflex, followed by a kissing balloon inflation with a drug-eluting balloon in the LED and non-compliant balloon into circumflex to sculpt the neocarina angioplasty. Here you must be thinking what I have said about this the kissing balloon angioplasty. You see, when we employ this ultra thin stent in circumflex followed by kissing balloon inflation. So kissing balloon inflation is a procedure that involves inflating two balloons simultaneously. Inflating two balloons simultaneously in a coronary artery bifurcation to treat lesions. This is hybrid procedure. And now you see, lastly, that we have made the neocarina angioplasty. We made a scalp, the neocarina angioplasty. So neocarina angioplasty is a procedure to treat percutaneous coronary bifurcation lesion that involving and placing stent to create a new carina. And you can see in this that stent has been removed. Before first thin stent, fully dissolvable stent developed in India. Before that, you can see that stent has been removed and blood is flowing very nicely. So now we take the third case. A 60-year-old male was admitted in 2017 with unstable angina, means negative troponin. He had a history of PCI to LED and right coronary artery in 2011 for myocardial infarction. There was very mild under-expansion in the new stent and the patient was discharged on dual antiplatelet therapy, aspirin and platelet. And after 6 months, the patient represented with unstable angina. This demonstrated the recurrence of ISR in the newly implanted stent at the exact same location of the original ISR and the unexpanded new stent. Now, to this we persuade lesser atherectomy to modify fibrocalcific disease followed by high pressure non-compliant balloon inflation. Following this, we were satisfied that the lesion had been fully prepared and a new drug-eluting stent was deployed, and you can see in the figure that stenosis is removed. It is seen in the corner last. Stenosis is removed and blood is flowing very well. And then intravenous ultrasonography before and after lesser atherectomy showing 29% luminal gain in machine, and patient remains symptom free after 4 years follow up. This was of the third case. Now we are going to case number 4. A 74-year-old female with a history of PCI to the RCA with 2 bare metal stents in 2003. Her medical history included hypertension, dyslipidemia, smoking related COPD. She presented with a recurrence of angina in 2019. Angiography at the local hospital demonstrated CTO, chronic total obstruction, to the RCA and she was listed for an elective CTO PCI to the RCA. Therefore, we took the decision to carry out rotational atherectomy through the old diffuse occlusive DMS ISR in undersized stent, and we saw there was progression of disease between and distal to stents. This succeeded in creating an adequate lumen which facilitated plain old balloon angioplasty, POBA, plain old balloon angioplasty, and intravenous ultrasound and lesion preparation was done, and subsequent stenting was a drug-eluting stent done. Subsequent stenting with drug-eluting stent done. The final result was excellent, and patient remains symptom-free at 3 years follow-up. You can see in upper zone, second number, the blood is flowing very well and stenosis is removed. Now we take the case number 5. A 63-year-old male had PCI to diffuse RCA disease with 3.5 into 60 mm drug-eluting stent, and this drug-eluting stent was named NextGen, ultra thin strat hybrid cell design. Again listen, NextGen, ultra thin strat hybrid cell design, cobalt chromium bare metal stent. The stent was well expanded with a good angiographic end result. Here you can see the last figure downward, the hybrid cell design and morphology mediated expansion of NextGen stent. And 6 months later, the gentleman represented with recurrence of angina. Repeat coronary angiography revealed critical ISR in the mid-RCA stent. Figure 17 you can see. Now optical coherence tomography was performed which confirmed a well expanded stent. After lesion modification with cutting balloons, a 3.5 into 15 mm thin strut, it is 82 micromillimeter. Drug-eluting stent was placed across the restenotic segment, achieving a good angiographic result. The patient has been symptom-free after 4 years, and you can see in the lower figure, lastly, that stenosis is removed. Blood is flowing very well. So in the last, we have reached to conclusion. Despite advances in PCI, ISR remains the most common cause of stent failure, accounting for 5 to 10% of all PCI procedures in modern clinical practice. Diagnostic tools like FFR, fractional flow reserve, and IFR, instantaneous wave-free ratio, and IVUS, intravascular ultrasound, and OCT, optical coherence tomography, often provide better insight compared with angiography alone and permit more focused therapies to treat these lesions. Current evidence suggests that DES stents or drug-coating balloons are the optimal treatment modalities for majority of in-stent restenosis cases. Intracoronary imaging can tailor therapy guided by ISR tissue pattern. The repeat revascularization may require and adjunctive devices to optimize vessel or lesion preparation prior to treatment with drug-coating balloon and drug-eluting stents to provide long-term durable results. Although data are available to currently support the PCI strategies. Further research will be necessary to distinguish which are the superior PCI techniques within this heterogeneous patient cohort. Thank you very much. Thank you.